Then for this interesting lecture. We're going to move on to the next talk for the interest of time. The next talk is by Dr. Chris Nabil, lecturer of radiology in Shams University, and she will be speaking on principles and technique of MRI guided biopsy for suspicious breast lesions, occult on sonomammography.
Good morning. My name is Chris Nabil, and I'll be giving a short presentation about the basic principles and technique of an MR-guided biopsy. First, why do we do an MR-guided biopsy? It has been proven and studied that preoperative and screening MRI identifies more synchronous, ipsilateral or contralateral breast cancers more than mammography and ultrasound combined. And this has an influence on the therapeutic decision, especially if the patient is seeking breast conservation surgery. In the preoperative and pre-treatment MRI, if a suspicious finding is spotted, a second look examination by ultrasound or mammography is advised. And if the lesion is identified with those modalities, biopsy guided by those modalities is preferred. However, in some cases, there are MR-only lesions that can be seen only by MRI, being occult on sonomammography, and in this case, we do an MR-guided biopsy. The contraindications, we have absolute contraindications, including those of undergoing an MRI, such as a cochlear implant, injection of contrast material, or interventional procedures in general, such as an abnormal bleeding profile. The relative contraindications include an unfeasible lesion, such as a small or a medial lesion, the proximity to an implant or the pectoralis muscle, and failure to visualize the lesion after contrast administration on the day of the procedure. Now, moving on to the technique, first we need the equipment, an MR device, and since high-quality images are required for proper biopsy planning and performance, a closed machine with a strength of a 1.5 Tesla or more is recommended. However, others prefer an open machine because it provides easier access to the breast as well as real-time imaging. Second, we need a breast coil. The breast is placed inside a dedicated coil that allows a good resolution of the images as well as it contains a grid. This is the grid. It's a sterile, multi-perforated landmark cube that contains a fiducial. This is the fiducial. It's the imaging marker. The grid is used for breast compression, fixation, and the biopsy system passes through it. And then for the biopsy system, all systems consist of the same basic parts, and they all have to be MR-compatible tools. First is the vacuum-assisted biopsy device, or the VAB, from 7 to 9 gauge, and the introducer set. The set consists of an outer plastic introducer sheath that has a depth stopper, which is a plastic donut, an inner cutting stylet or a trocar that goes inside the sheath, an inner plastic obturator that also goes inside the sheath to act as a marker during imaging, and the needle guide. The needle guide is a small cube that goes inside one of the squares of the grid. It has multiple holes through which the sheath and the VAB pass. Now for the steps of the procedure, first there is patient positioning. The patient is positioned in the prone or the oblique prone position on the machine with the breast inside the coil. The grid is placed with moderate compression of the breast to allow immobilization. And before starting the procedure, we have to take a localizing sequence, which is a T1 weighted high-resolution fat-suppressed image. This is the localizing sequence to ensure that the whole breast is included inside the grid. Then we inject the contrast material. We take the post-contrast and subtraction images to visualize the lesion and plan our approach. And in order to plan the approach, the sagittal and axial images are sent to a separate workstation. Here we can see the fiducial, the marker of the grid, and you can see there are faint black lines. Those are the grid. To plan our approach, we need to calculate the exact square on the grid to insert the needle guide, which hole in the needle guide to use, and how far deep the lesion is inside the breast, and accordingly we will adjust the stopper on the sheath. This is the square of the grid, this is the needle guide hole, and this is the location of the stopper according to the information. This information is obtained either using a computer-aided detection software that gives us all the information automatically, or it can be done by a manual method where the data is copied onto a worksheet that we use for reference during the performance of the procedure. Then we prepare our kit. The needle guide is placed into the appropriate square of the grid. The blue arrow points at the needle guide. The green arrow points at the fiducial. Then the cutting stylet is inserted into the plastic introducer sheath. And the depth stopper is adjusted on the sheath to mark the depth of the lesion. Then we prepare our axis. The skin is cleaned, local anesthetic injected, and the incision is made. Then we introduce and advance the stylet inside the sheath in a rotatory manner through the appropriate needle guide hole to cut through the depth until reaching the lesion, which is guided by the depth stopper on the sheath. Then we remove the stylet, leaving the sheath in place, and we insert the plastic obturator or the marker to be at the center of the lesion. And before starting the biopsy, we have to do some images to confirm that we have correctly targeted the lesion. The sagittal images will show the plastic obturator or the marker as a small dot that ends at the lesion, while the axial images will show the obturator along its whole length. It is this hypo-intense part, the tip of the obturator, while the hyper-intense line is the sheath itself. Then to do the biopsy, after confirming that we are in the correct location, we remove the obturator, leaving the sheath in place to guide the entry. The VAB, or the biopsy device, is inserted. Multi-directional sampling is performed in a clockwise manner. From 6 to 12 samples are obtained depending on the size of the lesion and the needle type. And after tissue sampling is complete, we lavage and aspirate the biopsy cavity to avoid hemorrhage and hematoma formation. After the biopsy, the device is removed, the obturator is reinserted through the sheath, and post-biopsy imaging through T1 FET suppressed images is taken to determine if we adequately targeted and biopsied the lesion. Here in this patient, the small hyper-intense dot is the obturator, and it is surrounded by a hematoma because of the biopsy. And as a final step, to mark the biopsy site for future reference and to facilitate subsequent intervention and follow-up, a titanium clip is inserted and deployed also through the sheath. And a post-clip placement, T2-star weighted image or mammogram can be obtained where the hypo-intense artifact is the metal marker. At the end of the procedure, the grid is released. Compression is applied to the breast for 5 minutes. The patient is instructed about the normal post-biopsy precautions and care. The sample is labeled and sent to pathology, and the procedure report is written. And after the results of the biopsy are revealed, we have to correlate the radiological with the pathological findings for concordance. If it's a concordant benign pathology, meaning that both radiology and pathology agree it's a benign lesion, the patient is followed up after 6 to 12 months by MRI. If it was an inadequate or a discordant sample, we have to repeat the biopsy or do excisional surgery. If it comes out as a high-risk lesion, the case is referred for MTD discussion. And if it's a concordant malignant lesion, the patient is treated accordingly. Now for the complications and drawbacks of the procedure, they are not common, less than 5%. Bleeding and hematoma formation are the commonest. The risk of infection is low. We have the possibility of the rupture of implants on which the patient should be counseled and consented. There is also the sensitivity or adverse reaction to the contrast material and the patient's inability to tolerate or continue the procedure. And the main drawback is that it's a time-consuming, expensive, and not widely available procedure. And now as a demonstration, we have an illustrative case. This is the mammogram of the left breast of a 43-year-old female who had a strong family history of breast cancer. She was diagnosed with invasive ductal carcinoma in the left breast after the biopsy and histopathology. Her pre-treatment MRI was performed to evaluate the extent of the disease and to exclude multiplicity because of her high risk. And MRI revealed another 8x4 millimeters BI-RADS4 focus in the left breast that was occult on sonomammography. And so a second look ultrasound was done, guided by the MR finding. However, it was negative, so an MRI biopsy was scheduled. The data was sent to the computer-aided detection software that calculated the grid square, the needle guide hole, and the depth of the stopper. This is the pre-biopsy imaging. We can see here this hypo-intense line, or the signal void, is the plastic obturator in place at the expected location of the lesion. The VAB was performed and the clip was deployed. And this is the post-biopsy imaging showing decreased visibility of the previously noted lesion, the clip in place, and the small hematoma. This is a post-procedure mediolateral mammogram of the left breast showing the clip placement. And final pathology came out as a multifocal invasive ductal carcinoma, which changed the management plan for the patient. In conclusion, MRI is known to be the screening method of choice in high-risk women and those difficult to evaluate for the accurate diagnosis and sampling acquisition. MR-guided interventions, although not feasible, but they are fundamental to any tertiary breast imaging practice because MRI has a high sensitivity but limited specificity. The basic steps of the MR-guided biopsy include approach planning, patient preparation, positioning, lesion targeting, and sampling with a VAB. And finally, radiology pathology concordance is the final decisive step for management. Thank you.
Thank you, Chris, very much for a very demonstrative talk. And now we move on